Hello, everyone. I'm Saleha, and this is Chai, Chat, and Community. Tonight, I'm chatting with Dr. Swati Mukherjee, who is an interventional cardiologist, with a special interest in heart diseases in women. She's among the only one of 17 women in interventional cardiology in Australia and New Zealand. Hello, Swati, and welcome to the show.
Hi, Saleh.
How are you?
Not too bad, thank you. Thanks for having me.
Oh, it's a pleasure, and thank you for coming. Um, Before we chat about heart disease in women, can you tell us something about yourself, please?
I'm grateful for the opportunity to come on the show. So I guess I'm a mother of 2 children. I'm a wife. I'm a citizen. I'm an interventional cardiologist and a diversity advocate. I guess that probably in a nutshell describes me. I guess when you talk about demographics, well, I'll go back to when I arrived in Australia, and that was in my early 20s. I'm female, I'm a visible minority. I arrived in the era of dial-up internet. I'm a first-generation migrant with a non-existent fallback plan. That's me in a nutshell.
And you're a great gardener, you're a great cook, all that?
All that. I'm an avid gardener, whether I'm great or not, that's something. I'm obsessive gardener, let's put it that way.
Why medicine, Shati? And why the specialization that you chose?
I guess medicine works to my strengths. I love to talk. It gives me an opportunity to talk. I'm social. It allows me to meet all sorts of people. I loved maths, and I guess genetics gave me some brains enough to do medicine. So I guess putting it all together, it put together my love of talking, being social, making a difference, and genetics to do it. So that's why medicine. Why cardiology? Cardiology is a very mathematical specialty in some sense. It's very logical. There isn't much airy-fairy, as we say, about cardiology. It's very rewarding, very unforgiving, as sometimes specialties are. If it is rewarding, it often allows very little room for error. But it's look, I mean, I think it works to my skill set. It works to my attention span. You usually you usually tend to make a difference fairly quickly at the end of a needle, and that is immensely satisfying. So you get a kick out of cardiology, I guess. And if you can, what wouldn't we do for a kick?
Absolutely. What wouldn't we? Thank you to everyone who is sending all these messages to us. Imtiaz Hussain, Shah Hussain, thank you. Swati, what is heart disease in simple terms?
So I guess as much as we all talk about heart disease, there's really no such thing, a broad term such as heart disease. So I guess probably I'll go back a little bit to the basics of what a heart does. And like I said, I like simple things. I like logic, and heart follows the logic. It really has 3 main parts. There's the plumbing of the heart, there's the electrics of the heart, and then there's the mechanics of the heart. And really, the heart is a glorified pump. So when we talk of heart disease, any of those 3 quarters really can go wrong. So you can have problems with your plumbing, which people, I guess, commonly know as heart attacks and angina, and all of those things are problems with the plumbing of the heart. So heart's its own blood supply to itself. Then there is the electrics of the heart, and then the people who have fibrillation or atrial fibrillation, you often hear about people having to be shocked out of a rhythm. Those are all electrical problems of the heart. And then there comes the mechanical problem of the heart, and that's when the heart as a pump fails because the muscle's failing. And that is often when people talk about heart failure or cardiomyopathy or genetic problems with heart and muscle, that's what they're talking about. So I guess in a nutshell, these three things encompass what we call heart disease. And of course, then you drill it down to so we, in some sense, we have cardiologists who subspecialize, and we call ourselves plumbers, electricians, and I guess maybe the pump people call themselves cardiologists. So that's, I guess that is probably a summary of what we call heart disease.
I was really surprised to learn from you that heart disease is the #1 killer in women. Can you please share some stats? Do you want me to show your
my screen?
With your screen, yeah?
Sure.
I'll move myself so that, it's easier. Just a moment.
That's okay. I can do that. You can still stay for sure.
Yep.
So I'm an overall always optimist. So I'm a believer. I wanted to show this to show that I'm a mother who has a child who has 2 children who look at me like this continuously. So I am an idiot for them.
Hello, Tishu.
So I guess that's the stats of cardiovascular disease in women. And these are data from Australia. So you can, as you all know, Australia is an all-comers health system. So we're seeing the problems of, say, even OECD countries like the US at the moment, where if you don't have insurance, you don't get healthcare, period. And that in itself has got lots of problems. But in Australia, we are actually very, very fortunate that you don't have to be rich to get a heart transplant. If you need it, you get it. We are an all-comers health system. Even in our very developed health system, cardiovascular mortality in women is actually really high. If I can put this in perspective, you hear so much about death in young women from breast cancer. By far, heart disease is a far bigger killer of young women less than 55 years old than breast cancer. So almost 3 times more women die of heart disease. So really, it's something that, I think we have really not appreciated as society or as doctors ourselves. This comes as I regularly do these talks to a wider healthcare community professionals, and it always takes them by surprise. And perhaps partly we are responsible because we've not done enough advocacy to put it out there. Breast cancer or advocacy has by far worked a lot harder to put it out there that, be aware, go early, go test early, have your mammograms. All of these saves lives. We've not done that about coronary artery disease. We're really starting to identify that we have, if there is one genre of people that have not benefited from all the improvement that we have made in the care of what we call coronary artery disease, which means people having heart attacks, then it is the only demographics we have not made any improvement is in young women. So women between 30 and 55 years of age. So whether we are older women, older men, elderly above 80, we have, the graph just comes straight down. We have made such improvement in death rates of people who present to us with heart attacks. Young women are the only demographics. If there's one thing you want to take away from these, please take away that young women do have risk of heart disease, and we need to be mindful. Don't write away a woman's chest pain. If she says that she's got chest pain, pay attention. So I think this graph actually quite nicely shows that if you can follow my, I'm hoping that you can see my mouse. Salima, can you see my mouse?
Yeah, no, I can, but is there any way of making it a bit larger? I'm just going to see. I can't seem to. I'm just going to.
That's okay. I mean, it's
No.
just the top. On the top graph, you can see that everyone's has, all the lines are sloping down except that last line on the graph, which is pretty much a flat line from 1979 to 2011. So that's women between 25 and 54.
Wow.
So it is a scary statistics that we have gone marched ahead and reduced mortality in all ages apart from women. So there's been a lot of focus in the recent times. There's a little Time magazine cover that came out, which again sort of talked about the same thing, I guess, is your biggest worry breast cancer. Think again, 1 out of 3 women will die of heart disease. And so we do a lot of work in sort of trying to spread this message that women do have risk of heart disease.
And this is across the board, isn't it? All South Asians?
This is across the board, every population. So this includes Caucasians, South Asians, Asians, indigenous.
Women in general.
This is women in general. In fact, if anything, South Asian women are probably at higher risk, as are South Asian men. They have above average risk of when I say heart disease, I mean coronary artery disease, so of heart attacks. Let me rephrase that. So it is we understand that we're talking about heart attacks as opposed to rhythm problem, electrical or heart failure problems. So both South Asian men and women have higher risk, but then we have made improvements in all of those demographics except for young women across the border, including South Asian women.
Wow. So you've kind of answered my next question, and you have, which is about younger women having heart attacks. So yes, they do have heart attacks.
Yeah. They do, and they actually present slightly differently, and that might be why we miss it. And this is actually a really helpful slide that that you might want to take away from, which sort of talks about the symptoms of heart disease in women. Women don't necessarily present with the crushing central chest pain that we talk about. So it's so sometimes you can get jaw discomfort, sometimes you can get neck discomfort, or a burning sensation in your throat. You can feel it in your back, shoulders, arms. Often women will present with dizziness, cold sweats, nausea, shortness of breath. It's a very helpful Heart Foundation resource that I think it is worth spreading the word. So if all of you can take away to your community, all of those of you are watching, I'd be very grateful. I'm sure each one of you could just save a life.
Thank you. Swati, what are the symptoms?
So I guess most commonly, both men and women, the common things are common. So as much as we make a deal out of women having, it is more because we have not recognized that women get the same sort of symptoms as men. And I guess we're trying to focus on that. But the commonest symptoms are still chest pain. So often it is central crushing chest pain, which is not worse with movement. It is often associated with profuse sweating, nausea, vomiting. Sometimes it is never really severe chest pain. And I think that's probably what people mistake. Often people expect that if I'm having a heart attack, I'll get really severe pain, and people don't. It is often grumbling pain. And the commonest thing that people think about when they're getting this discomfort is indigestion. So very, very similar to that sort of low-lying discomfort more than sort of crushing chest pain. And if that goes on for long enough, yes, it could be indigestion, but it could also be a heart attack. So keep your antennas up. So apart from that, often, I guess there's lots of different ways people present, and that could be with shortness of breath, with nausea. I've seen people just with elbow pain present with both sides elbow pain, just generally feeling unwell. But the commonest thing is that you do have central chest discomfort, which often people say, oh, but I thought it was indigestion. I tried some Mylanta, I tried some Nexium or any of those things before I thought, oh, this is not going away, I'll go to hospital.
So how do you differentiate between an anxiety attack and a heart attack?
So anxiety attack, I always say to people, is a diagnosis of exclusion. So when someone's restless or someone's feeling uncomfortable, can it be anxiety? Yes, it can. It can mimic very closely, but that never should be your primary go-to diagnosis. I think women particularly actually get often diagnosed with anxiety, because women often do also fluff around with their symptoms. They often say, oh, I'm getting this, but it must be because of this, that I must be anxious, I must be worried about something. Women tend to, I still remember a patient who had she was wheelchair dependent, and she'd gone shopping and lost her wheelchair. And she had developed some chest pain shortly afterwards, as it happens. It was very difficult to pin her down to chest pain. She kept talking about her wheelchair and the fact that she lost her wheelchair. And the whole description was like, but you haven't come to the hospital because you had a wheelchair. What happened? Oh, I got so anxious and sweaty that I had to come. So women often weave stories, start to believe themselves that they've got something else. And she was having a massive heart attack, and that had got nothing to do with the lost wheelchair, which she put the whole blame of the discomfort that she had. So I think women in particular can complain about anxiety, but I think if in doubt, call an ambulance. They can really mimic very closely, and one drives the other. If you get chest discomfort, you get anxious, and then you feel like you're getting anxious, and so it's very hard to tease out the two. And I'd strongly suggest, if you're out there in the community and you feel you've got some chest discomfort and you think it might be anxiety, it's probably better to get some help. Better err on the side of caution. Anxiety doesn't kill, and heart attacks do.
Absolutely. What are the preventions?
So I guess shortly, again, sort of, whilst I'll focus on women a bit more, but remember, I'm aware that we should try and aim at gender equity as we talk about it. So I'll just, I guess, common risk factors are common. So common risk factors are high cholesterol, hypertension, diabetes, smoking, elevated BMI, which means being overweight, all of this, and family history. Those are all common across genders, risk factors, and common things, remember, are common. For South Asian communities, especially family history and hypercholesteremia are often familial. There's a very, very high incidence of using of family history, because as much as we don't call it genetic, but it seems to cluster in families. So we think that it might be driven by familial hypercholesteremia. Perhaps, we didn't know that they had high cholesterol back in the times, but we know that they had heart attacks. So often it is very common, and those would be across genders. Those would be the common risk factors, which we really should be aggressively managing. So, and certainly we are very lucky in a country like Australia, where most of the preventative programs that are done by Heart Foundation are free, and there's a lot of literature, and even in Hindi, and if you go to the Heart Foundation website, there's a other languages resources thing, and you should be able to access those resources as to what you should go and ask your GP, what should you monitor, what sort of blood pressure, if you're monitoring your blood pressure at home, what sort of blood pressure you should be looking at, what is the good and bad cholesterol, and what really is what your aim should be. I always say to people that take ownership of your health. It is important that you know what you aim at, so that you can go and ask your doctor, well, doctor, if you say it is okay, what does that mean? What does being okay mean? What does being stable mean? Ask for the number. There are guidelines out there for you to follow, so you can be a partner in your healthcare yourself. So ask the questions. All of us are almost always happy to answer your questions and ask for explanations. There is nothing wrong about asking. Take ownership of your health. In fact, we like people who will take responsibility for their health. It's not always just the doctor's job. It's a partnership, and that's how it should work. Women, just coming to women, I guess I'll just bring out some data. I think you can speak. Can you see my screen now, Salia?
No, I can't. No. Yep, I can now. Yes.
So I guess women in particular, and I guess we are starting to recognize, and that's why there is a focus, is because now we know that we can do something about it. There's no point sort of saying that young women die from heart attack if we don't know what we can do about it. And we are starting to learn a lot more in the last 10 years or so about particular risk factors of women. So those of you out there who've had problems with pregnancy, so problems like high blood pressure during pregnancy, preeclampsia during pregnancy, or gestational diabetes, small for gestational age babies, all of those complications of pregnancy, we are realizing, are actually risk factors for heart disease, much like smoking and hypertension and diabetes. And if anything, if I can show you that if you get early preeclampsia, your risk, what we call relative risk, is 7.7, which if you think diabetes is 4.6. So apart from familial hypercholesteremia, which is often not the garden variety high cholesterol we all get, it is more cholesterols around 11, 12, 13. That risk of preeclampsia, early preeclampsia, is double the risk of if you have diabetes. So if you can imagine how much we worry about diabetics and heart disease, then you can these women who we send out, you've delivered your baby, your eclampsia is gone, your blood pressure settled, off you go and live your own life, and we don't follow them. We are increasingly beginning to realize that these are the women we should be getting back to the general practice clinics or to women's heart centers to follow them once every 12 months or so, measuring their cholesterol, measuring their diabetes, promoting healthy lifestyle, healthy weight, watching their BMI, their exercise, all of those sort of things. So I think it is important to sort of keep in mind that so the women in particular, there are some new emerging, what we call emerging risk factors. And if we can catch these people early enough, then like we have made a difference for all everyone with diabetes and high cholesterol and smoking and all of that effort we put into dealing with these risk factors to reduce the risk of heart disease going forward, we can address these in young women in particular to try and reduce their risk of heart disease.
I think you travel a lot overseas on conferences. Do you want to share the work that you do?
So I guess, as I mentioned, I am a diversity advocate. So I do a lot of work in both heart disease and women in cardiology. As Saleha pointed out, I'm only one of 17 women in interventional cardiology and on all of Australia and New Zealand. Now, if you put in perspective of how many men there are in that, it is in the thousands. So it is a very, I guess, gender undiverse specialty. And usually the talk has been that women don't want to do it, or women are not capable of doing it, or women don't like the on-call or the stress of an acute specialty. One by one, we have tried to take away this myths, mostly by science. So we have actually done lots of research and collected a lot of data around Australia and New Zealand, particularly in women in cardiology. And I now am a gender equity selected representative for the Royal Australian College of Physicians across all physician specialties of Asia Pac. So about six women on that board. I'm a first generation migrant woman of color to be selected. It is an honor, and hopefully I'll be able to make a difference with the work I do. And hopefully people coming after me won't have to listen to the fact that you guys can't work 22 hours a day, you've got to be pregnant, you've got to be mother, you can't do this, that and the other, so you can't do cardiology. So hopefully people will understand that life is about a balance. As much as I love cardiology, and I say to my children that, I'm probably one of the few people who goes to work to be happy, and it is my happy place. It's where I make a difference. It is, but cardiology is in my life. I am a mother. I am a wife. I have lots of interests, including chit-chatting and Bollywood movies. At the moment, dying on Fawad Khan. That was before. He's replaced Shah Rukh Khan now almost. Although I've now encouraged. I've talked to my cousin's 4-year-old so much that she's only wearing Shah Rukh Khan's shirts. But I have lots of interests. I like to live.
You forgot Dhoni.
I forgot Dhoni. That's right. Dhoni's retired. It is a typical. I'm becoming a millennial. My attention span is about 2 minutes. It's the next frame. So I guess life is about finding that balance. None of us get the balance right, I don't think. And there are parts in our career paths when we spend more time being mums than cardiologists, and there are other times when we spend more time being cardiologists and less being mums. And as my children grow, I have spread my wings, and I've gone on to do a lot of advocacy work, a lot of research, a lot of science to back, so that people can't just say, oh, this is just some mad women just rumbling around, talking about bra burning. We have with science tried to show that, look, if this is what you're saying, that's actually not what's happening. If you're saying that women don't do cardiology because they don't do on call, then how come obstetrics and gynae have got 98% women? Because they do on call as well. So you can't really just blame on call and say women don't want to do cardiology. So we've tried to address these barriers. I do a lot of international speaking, and I guess I'm a member of SKY and Women in Innovation, which is the US peak body of interventional cardiology. It's an honor to be a part of that, and as a part of that, I do often speak about mentoring, the importance of mentoring, about the importance of having peers who will stand by you, but also putting your hand up in the room to if you're not in the room, you're not in business. So you've got to put your hand up, show your face, and stand up and make your point. And you may not at that point in time make a difference, but hopefully someone somewhere will take that away and hopefully use it and amplify and escalate and hopefully get better outcomes. So I guess a lot of my international speaking is about women in cardiology and heart disease in women. I have particularly worked hard, and I guess I understand that I am very well placed to do that. I'm very privileged to be a first generation migrant who has got the opportunities that I have. This country has given me, the country of my birth gave me the education, and my family, my father, who as who again as a son, first generation son of a refugee family, supported my education, didn't say that she's a girl, what's she gonna do, why do I spend my money on her education. He did. He supported each one of my my moves. In fact, as one of the things that I didn't mention, I came to Australia chasing a man. Many a patient have told me, Swati, that's just stupid. Men chase women. When are you going to? Well, there you go. I have smashed that thing as well. That idea as
You're
well.
breaking too many glass ceilings now.
I did. So, but my dad did. He stood by me and he said, well, you know what? If nothing works out in Australia, you can come back to small town Rourkela, and you've got a home. I can give you roti sabji, and there you go. You can practice medicine here if you wanted to. So that was my fallback plan. But he always just encouraged me, and he just said, well, if you don't try, you don't know whether you're going to get it. And that is an amazing privilege to have. I think, I have to count my blessings that these things came together for me. I got an amazing family. I got some genetics. I got support. I have to acknowledge I got support from my husband and my children, who have all Irabans lived inside every resident quarters of Melbourne hospitals, and my friends, who we don't have family here, and my friends, who have picked Iraban up from childcare when I'm running behind. Bishopjit, I probably should mention, has come to my house.
I'm hoping they're listening to this.
Yeah, 3 a.m. to look after Iraban when I have not been able to pick Iraban up from the bed to take him to hospital. Ishita multiple times has picked my children up from childcare or school and fed them. I couldn't have done it. A lot of things came together for me, so it's a privilege. And I guess I do a lot of advocacy work around the world now. I've used my reach to hopefully may have some impact long term.
Thanks, Shati. It's been great speaking with you. I'm having a lot of internet problems. There seems to be some kind of a lag, but anyway, thank you so much, and thank you for sharing all your knowledge. And even if one person is affected, and I think we've done a job.
Thank you so much, Saleh. I'm really grateful for the opportunity.
Okay. See you soon. Bye.
Bye.